or lacking information in the way that the studies are reported. We also found some common equity challenges across the different reviews. We noticed this digital divide, and that was mentioned a little bit before by Michaela when you were looking at the responses from the poll. The lack of equipment, of knowledge, of ability to use the systems in different geographical areas, or depending on income and age as well. We noticed also that certain elements regarding gender, regarding employment, regarding different ethnic groups was very much underexplored across the different studies. It was noted that there is a low digital literacy among both patients and clinicians, which we found interesting. And we noticed that there was mention, although not systematically, but there was mention of caregiver burden, but how it can disproportionately affect women. And lastly, we noted across the studies that there is limited cultural adaptation and inclusion of the Indigenous and rural communities in the different studies.
If I
delve a little bit,
I just want to add that there were very few studies also that explore caregivers, and that's also one of the objectives of this project, is to talk a little bit more about caregivers, to get their perspective as well, which we found that was lacking also looking at the rapid reviews.
Perfect. Thank you. Thanks, Jennifer. So if I go a little bit deeper now into the individual rapid review, so what we did was we conducted a large rapid review and then broke it down into specific areas of interest. So if we looked a little bit closer at the rapid review regarding physiotherapy and occupational therapy, and we have some of the members of the team who worked on that who are here today. While we did find that, I'm just going to move again. I'm sorry. I'm just going to move the screen. Okay. While we did find that telerehabilitation does and can increase access in rural regions, and also in individuals with mobility issues and low income, we did find that over 50% of the studies did not report any ethical outcomes. So most, or half of our studies at least, did not report any ethical elements. We found that there was an inconsistency in the reporting of adverse events. We found that they're not mentioned in the body of the results of the study. They're sometimes mentioned in the discussion as potential risks that can occur. Some of the risks or adverse events that were mentioned a little bit, but not really detailed enough, were due to poor image resolution, in particular in some professions in physiotherapy and occupational therapy where you may need that can be important. The studies did show a new focus on self-care, but the concern with that, so people may be more at home, for example, and so there'll be a little bit more of an emphasis on self-care and empowerment, but sometimes it may exceed the individual's capabilities, perhaps the resources that they have, and could lead to feelings of abandonment. One of the elements also that came out was that there's space constraints when you're talking about telerehabilitation in a home-based setting. So depending on the intervention or the evaluation that's being done, that can be a concern. It was noted that there's training gaps for clinicians in using the different digital tools that are needed for telerehabilitation. And you'll see that I'll bring that up a bit later also in the survey. The studies had very little exploration, they would mention, but very little about age, gender, sexual orientation, or other cultural factors that could impact on their use of telerehabilitation, their accessibility to it, their need for it. So it was interesting, male patients seem to have a greater reliance or use of telehealth. The female ones seem to experience worse outcomes and had more caregiver burden, as I mentioned a little bit earlier. There was a lack of reporting on costs that I mentioned earlier, and that was across the board, and that remains true for studies since my studies during my PhD a long time ago. So that has not improved much, and it's still one of the elements that's often mentioned when telehealth is mentioned in general, is that it can help save costs, but there's very much a lack of comprehensive reporting on costs. We don't actually know who will bear the costs and who will benefit from having the telerehabilitation. Internet access, equipment were listed as potential barriers, as well as the lack of human contact and feedback. Now, if we look a little bit more at one of the reviews that looked at the older adults, what was interesting is that most of those studies that were focused on older adults and telerehabilitation did not address any of the ethical aspects of their intervention. There was often or sometimes a mismatch between the technology design and the actual user needs, and that may link into the point here about ageism in technology design. Older adults are not always included in the design of the technologies and in identifying their needs. And that can lead to technologies that cannot be used by some people, or with a perception that it's not appropriate for older adults, and then they're not included in telerehabilitation activities. Some of the barriers to telerehabilitation use were the fact of having chronic illness that may impact on the ability to use and benefit from telerehabilitation. Different sensory impairments like visual deficits, hearing impairments, and the lack of digital literacy. What was interesting also was the discussions about, or the element that came up about care versus empowerment. So if we're providing care and treating, or are we trying to, I mentioned self-care before, empowerment, are we trying to get people to to become more empowered and take care of their conditions? And that's definitely self-management is an approach, in particular in chronic conditions. But at the same time, are we overburdening patients or their caregivers? And there was very kind of mixed results between gender and race. There were many more women participants, white participants, although we had really a lack of information regarding the different characteristics of the participants in the studies in these reviews. One of the other reviews looked more specifically at speech language pathology. What was interesting is that in this field, there was the greatest level of acceptability of telerehabilitation by the therapists. They were the ones who seemed to really use it more with their patients and find different applications for use with their patients. Interestingly here, we noted the shift in focus. The earlier reviews, when we talk about ethical and equity aspects, focused more on privacy and confidentiality issues, data security, and infrastructure available. And the later ones went more towards consent, safety issues, and the clinical relationship that developed between the patient and the caregiver and the clinician. What was interesting was that adverse events, again, were rarely mentioned. Autonomy, the patient's right to decide, to choose, and dignity were rarely mentioned across the studies. We noted also that telerehabilitation can improve access to care, as we've noted before, can in certain cases potentially lower costs and improve language equity. So interesting that it provided more access to care for certain languages, in particular, for example, heritage languages. We also noted that although access to technology was improving or is improving, there's an assumption that there's access to devices universally, or it's becoming much more universally accessible, but it could be misleading because the studies underrepresented people with no access. And that was mentioned a little bit earlier by Jennifer, I think. And finally, an issue that came up was the issues of licensing and cross-provincial boundaries and how that limits access to care to telerehabilitation in Canada. And the last one I think that I wanted to talk about is a rapid review looking more specifically at psychology and neuropsychology. And one of the main issues that came up in that one is privacy issues and the need for private controlled environments to have the sessions, and that often is not possible, whether it's in the patient's home or wherever it's taking place. Um, Access issues were often overlooked. They weren't mentioned. We would identify them in the study, but it wasn't necessarily mentioned by the authors. We noticed that the caregiver role is here in this case also came up as important, and that in some cases it can reduce the burden of care by perhaps having the care being done or the interventions being done at home, but in some cases can increase the burden of care by having the caregivers in a different role. Again, there was often underreporting of sociodemographic data, adverse events that don't allow us to draw a lot of conclusions on that end. There were some elements of strain on the clinician-patient relationship. So we noticed that the therapeutic relationship is not often addressed, but in this case, sometimes it is addressed and there is mention of some of the strain that it can cause. And finally, some of the equity blind spots, things that we noticed were really not addressed in this literature in particular, were some of the differences that there may be between different ethnic groups and socioeconomic groups and their access to telerehabilitation. So some of the recommendations that came out of there for future practice and for future steps are to develop some standards, some ethics and equity standards in reporting telerehabilitation studies to really allow us to draw better conclusions. Also, we noticed that the idea of co-designing some of the tools, the telerehabilitation tools, in particular with the more underserved populations and aging populations, would be very relevant. It's important to include the caregivers, to include the older adults when implementing, when planning implementation, when designing the tools, but also actually putting them in place, and to further support the clinicians in their training for digital health in general, but in this case, equity and ethics. So that gives you an overview of some of the findings from our rapid reviews. And I'll just move on to present quickly some preliminary results from our surveys that we've conducted. So one of the first surveys that we launched across Canada was a clinician survey. And we had nearly 700 respondents across Canada from the different rehabilitation disciplines. On average, people had about 15 years of experience, although that range. We had many more women than men respondents, but I think that's a little bit representative of the rehabilitation disciplines in general. And we had a good representation of the different disciplines across Canada. We had a lot more people from the public sector, responded to our surveys. And we had more people in Quebec that responded because we initiated it there. So that's not surprising, but we had respondents from across Canada, which was really nice to see. One of the interesting elements that came up in these surveys was that the clinicians did tell us that they had received some training in telerehabilitation, but that they would also, nearly 2/3 of them, or a bit more than 2/3 of them, wanted to have access to more training in telerehabilitation. And one of the elements also that came up is that they have access to guidelines, but they don't necessarily use them. And so some of our findings were interesting in that perspective. So we need guidelines, we need guidance for our clinicians, but they're not always having access to it or using it. The respondents to our studies were clinicians who worked across the spectrum of conditions in rehabilitation, with a large chunk in neurological conditions and musculoskeletal conditions, some in cardiorespiratory, and we had people who were in different geriatric conditions, quite a few who saw patients with communication problems, which was interesting because that also came up as sometimes a difficulty in using telerehabilitation, and a few who used telerehabilitation with patients who had vision and hearing problems. And again, that did come up as one of the limiting factors sometimes in being able to use telerehabilitation. Some of the main barriers that were mentioned by our clinicians were kind of similar, somewhat similar to what we found in the review. I just want to highlight a few here that I thought were particularly interesting. So limited nonverbal communication is seen as a barrier, but at the same time, we do see that clinicians do use it with patients who have limited communication abilities or who have communication disabilities. So that there's this kind of conflict, probably something to delve in a little bit more into it to see what alternatives are there to allow patients with communication difficulties to have access to telerehabilitation. Interestingly, clinicians reported that they found it difficult to integrate into work routines. And that is something that the literature showed that the more it's integrated into work routine, the easier it is to use and the more it becomes sustainable over time. So if it's challenging to integrate it into work routines, you're going to have a difficult time integrating it over the long term. And that kind of relates also to interoperability. So the studies, the rapid reviews showed some of the challenges with the equipment and the softwares, but one of the elements specifically related to the telerehabilitation platforms is the difficulty with it being able to operate with the other systems in their settings. And that may be particularly unique to the public sector or to certain settings. We need to delve in a little bit deeper, but definitely thinking of how to integrate it with what's already going on with your routine and with your current system seems to be critical for it to be used by the clinicians. Interestingly, you had a perception of the lack of effectiveness of telerehabilitation, despite the literature really showing that telerehabilitation can be used as effectively in a number of patient populations across the spectrum of types of disabilities and different across the continuum of care in rehabilitation. So I thought that that was something interesting. And another interesting element was the resistance to change. So not wanting or not being ready to necessarily change and jump on board and use telerehabilitation as needed for the different patients. So what are the next steps for our team? Right now, we have an ongoing patient and caregiver survey. So you have the QR codes here if you want to take a look at them, if you want to share them with anyone you know who may be interested in responding. That includes people either who have used telerehabilitation as well as those who haven't. And I should mention that actually for the clinicians, all the surveys included those who did not use telerehabilitation but wanted to give their opinion about it for us to understand why in some cases it's not used when potentially they wanted to use it or it could have been used. And then our next steps are going to be to conduct some interviews and some focus groups with different key stakeholders, patients, caregivers, decision makers, managers, to try to delve a little bit deeper into some of the findings that we found and come out with some recommendations and possibly some kind of a consensus position statement from our team. So just to remind you, we have the website if you want to visit it. Oops. We have our Facebook page. And I think that will be it. So thank you for your attention. And I think the next will be to open it up for the discussion, and we have a few elements for discussion here. So I don't know. First, I'll let Michaela let me know what I should do, and then I can leave it up here or not.
Thanks so much. This is such a helpful presentation. I love how you broke down some of the data that sort of backs up what our community has been facing in terms of challenges, and some really interesting stuff too about the potential facilitators, like even the language stuff that you shared. Yeah, we can open it up for either, I don't know if you want to take just general questions first, and then I love that you've got discussion prompts. Those look really interesting and actually like aligns with, I was trying to write notes to myself as well, and some kind of thoughts, which is totally in line with what you prepared already, which is so appreciated. Yeah, so first, do we want to see if anyone in the community has any general questions? You can just unmute yourselves and ask them, or I'm also keeping an eye on the chat as well, if you're not able to. And Linda has written in the chat, hi Linda, curious to know if there were respondents from Northern Territories and Newfoundland, so like not a maritime province.
I'm gonna let Jennifer respond. She's looked at it closer.
Yes, there were some, but they were about like I would say 4% of our sample. So we haven't dig in too much yet to explore it. We want to kind of put it aside and really take the time, but we've been having also some great discussions about what could be like potential steps for us to include them more, because we were told sometimes that a survey might not be the best idea. So we are currently, we're a team of researchers thinking about other avenues as well, you know, maybe for the interviews like Dalia mentioned, you know, like focus group, how we could get their perspective as well a little bit more, because I think when we're talking about specificity, geographical barriers, for example, their point of view is particularly important. So yes, thank you for your question.
Yeah, thanks so much. And I think along the same lines, Andrew was wondering about responses from Nunavut, but I think probably that'll be part of your next analysis, right?
Exactly.
Thank you.
I'm not sure. Okay.
Oh, sorry. I
Sorry.
totally talked over someone.
That's okay. I'm not sure if you can hear me.
Linda, yes, go ahead.
So thank you for answering that, and I appreciate your answer. We are a very small group when it comes to nationally, but the Yukon, the Northwest Territories, and Nunavut, we've used telehealth in our practices for 30 years. So at least 30 years, because I was using it in 1995 when I was working here. So if you are interested in getting some experience and some information and how we've been using it in the northern parts of Canada, then contact me or Andrea. I see in Iqaluit, and I see Lauren's on the line here too from Whitehorse, and we can certainly make sure that we can put some groups together to help you out.
Thanks so much, Linda. That's so appreciated. It's like so great.
Thank you very much.
Yeah,
very relevant.
It is very appreciated. In fact, because I can tell you that we've been facing some challenges in getting you know, connections and all of this. So, you know, like any help that we could get, we would really love it. So thank you very much for that.
Sounds great. Thank you.
There's some more activity in the chat about contacts for you both. Andrew was also wondering if there's translation of your surveys. Like she's asking what, I'm gonna not do well with this. And no, I'm so sorry, Andrea. I'm ignorant. Yeah, can you speak to sort of translation?
So we translated them. We have the French and the English versions, and great question. They are not translated in Inuktitut. I hope I pronounced that correctly. And it's a really good point. I wonder, you know, I think that would be part of a discussion that we should have, because I can say that we did not until now, it hadn't even come up, even though we have a large group of researchers and partners. So I take note of that, Jennifer. I find that interesting. I think we have had questions, for example, is it available and accessible to people with visual disabilities, for example, who may be using devices? So we've had different reflections and thoughts on how we can make some of the surveys more accessible, but we had not made a note of that. So thank you for that.
Thank you. And yeah, I see that there's lots of great context you'll be able to look at in the chat. I can make sure you've got them after from Lauren, Andrea, Melissa, and also Kaylee and Rebecca about connecting you with eastern part of the province too. So thanks so much for our community. This is wonderful. Angie, you've been waiting so patiently with your virtual hand.
No,
Please go ahead.
No, I just so enjoyed that discussion, and I don't want to change direction if there's any more, because this is a true community of practice, Michaela. That was really great. I guess I wanted just to start off with a thank you, Jennifer and Delia. This work is just so interesting. I'm just like eating it up, and I partly because it picks off where we abruptly left off when we did some real-time patient, family, and experience data during COVID, where we asked not in as nearly as good detail, but we did it consistently and had large internal cohorts to really understand how, where, and what, and all of our questions that we knew we needed to answer were all in exactly where you've picked up. So thank you. So starting off with a thank you. And as I put my physiotherapy hat on, I'm so interested in this idea of cost. And it came up a couple of times. And I know that you said it was, still swirling, but could you speak to cost and this tension about who picks it up? I'm really interested.
Yeah, so actually it's an area that really interests me and that I've never been able to dig deeper into, but since my PhD studies, I found it interesting. And postdoc studies. So what I find interesting is that the costs that tend to be reported are a list of cost, list of equipment, maybe human resources. That's about it. Travel distance, if travel was avoided. That's usually what's included, maybe space. Okay, but then sometimes when we use telerehabilitation, we reorganize care and maybe the home care organization is now the one taking on a certain responsibility that the rehabilitation center would have been doing. So now the cost has been shifted slightly within the healthcare system. Or does it, for example, for the patient, from the patient perspective, does it avoid having to have a caregiver take them to their appointments and therefore avoid the caregiver missing out on the work, for example, or things like that. So there's a lot of nuances and information that's not reported in the studies and not captured. And the different perspectives are not analyzed. It's really just usually a listing of costs. And I think that's a shame because it's kind of thrown out there as sometimes a cost-saving strategy or not, sometimes as being very costly in terms of equipment, less so now because more common equipments are used for telerehabilitation. So it doesn't tend to be these hundreds of thousands of dollars of equipment that are needed. But it's kind of put out there, but without any very solid evidence, I'd say.
Thank you. So interesting.
Thank you so much. Now, there's been a little more activity in the chat. So question for you two. Do you know, have you got approval for research in the Inuit communities? That's what Andrea is wondering in terms of being able to actually share your work that way.
Good questions. We'd have to explore for the different areas. I would say most likely not. And we would have to go through the steps if we wanted to specifically collect some data there. It's challenging doing a pan-Canadian study, and I see we have different members of the team on the call. We have Mirella Veras, we have Reja Banowski, Jennifer O'Neill, and I may have missed people, I'm not sure. And they helped us get the ethics approval for each of the provinces when we wanted to disseminate the questionnaires, the surveys, and even do the other steps eventually of the interviews and focus groups. So even just across provinces, we had to do that, and we would certainly have to do that. And we would probably have to go back to our ethics committee, initial ethics committee, to be able to include that patient group, and then go to the setting. So that would take a discussion for sure.
I might just want to add that we did wanted to explore this avenue more at the beginning when I joined in. So that was maybe 2 years ago. One of the things that we were told back then, which might have changed, but we were told that, and I don't remember which specific area it was, but we were told that they were not accepting new studies back then. So that, I remember it being one of the reasons why we decided to at least, you know, we would explore it a little bit later or something like that, because we were told that they were already overwhelmed with lots of research and they were not even accepting any new research. Exactly. So Sandra said, yes, urban community. Exactly. So I remember that being one of the challenges that we faced back then. Now we did try to come back to it later on, but I have to say that we face, you know, additional challenges when it comes to this, right? So we've been trying, you know, other ways as well, but it's difficult if, you know, you cannot get the ethics, and, you know, you're being told you can submit the research, you know, so you have to wait a little bit. So like I was saying, someone mentioned in the chat that maybe a meeting with all the representative from the north. I think that would be an amazing idea. Thank you for that.
I agree. So I'm so loving everyone's collaboration. So I have made note of those of you that have passed on your emails, Lauren, Rebecca, and Melissa. So I can send an email at the end just to link everyone with you too. Andrea or Kaylee, if you wanted to be part of that too, just let me know, and I can add you as well. Because I do feel like one of the hopes that we had with having sessions like this is to learn about incredible work like you two are doing, and also be able to link together, especially if there's been areas like you mentioned where you've been trying to, like, there have been challenges. I think this is where, like, having like local, like, champions from all across the country is really amazing.
Excellent.
So now, okay, thanks. So yeah, Linda, I'll add you too. So do you guys want to pull up your questions now? This might be a good time to look at those.
Just for some food for thought.
More food for thought for us before we wrap up this incredible session.
Might be a good time for me just to say that I have to leave in about 8 minutes, unfortunately, because I'm teaching. But Dalia will stay on to answer more questions.
Thank you, Jennifer. So some of the questions that we wanted to put out to all are, what are the biggest barriers or challenges either that you face with your patients to access telerehabilitation, or that you have heard that are faced, either that or that you faced yourself potentially, or as a caregiver? Are there any success stories that you wanted to share with us? Any equity success stories where certain groups perhaps have been able to gain access to care that they maybe wouldn't have had access to care to without telerehabilitation, for example? Do you have any ideas for improving accessibility? And we were talking a little bit about that with the northern communities, accessibility and equity in telerehabilitations. And then maybe a last element, what patient groups do you think are likely underserved with telerehabilitation? I'll just leave them up there.
Yeah, thanks. I think we've got Melissa's got her hand up. Go ahead, please.
Hi all. I'm just, for context, I oversee like a chronic condition support program. So we do a lot of cardiac rehab, pulmonary rehab, and home health monitoring services in the territory, Yukon, sorry. And it's kind of an interesting barrier, I would say, in the sense for some of our rural communities, I find that patients lack incentive to actually attend programs. Especially in our smaller communities. I find they're just used to like I don't know, unique models of care. And so I think when we try to put them into some of these structured programs, that is hard. And then they kind of like to just be able to access services when they want. So that's one challenge I would say that we face. And the incentive
So
component
just
for
to
some
clarify, it kind of doesn't match with this concept of the way they would get care, perhaps?
a lot of things that happen in our small communities, like again, they just present to the healthcare when they want it and when they need it. Like, you know, it's like scheduled appointments is generally poorly attended overall. And
Okay.
so some of that is there. And I think also for some of our small community things, elements like cardiac rehab or some of these kinds of programs are funded for travel. So that's also de-incentivizes them to attend virtually in some ways, because why would I do that when I can get paid to go to town to go to programs potentially or access services in town, and then they get their shopping done and all those things. So also kind of a different kind of challenge that you can see with some of these smaller northern rural communities where there's like good incentives for them to like travel in, as inconvenient as that seems. So we try to bolster like, oh, well, you won't have to travel in. They're like, oh, but I but I do my shopping and I get gas money to do that. You know, so it's kind of an interesting alternative perspective, but that's one barrier we have as well. And yeah, I just think that there's perceptions and the lack of support for some of our rural communities, certainly, where we can send somebody them to help with technology, right? So like if we could send a home care nurse in there to help them like get set up and get used to the devices and so on and how to access programs, like if we can get that level of support, I think we would do better. Those are just my
Very
sense from
interesting.
Yukon.
Excellent. Thank you. Thank you for sharing that. And I think it shows the differences in you can perceive travel as a negative, and you can perceive travel as a positive. So that's what comes up a lot in the literature that we're looking at and in the surveys, and that we want to delve deeper in. And you really need to do these more localized kind of studies to really understand that, because it's different in different contexts.
Just to add to that, I think, unfortunately, yeah, I do think about overall for some of the contexts, there's not, again, patients need incentive and their own health is often not enough.
Oh, Lord have mercy. Sorry, y'all. My computer decided to crash. So I missed some of your awesome spiel, Melissa, and I'm so sorry to have missed it, but it sounds like it was a great discussion. And we do have a few more minutes. Now, I know, Jennifer, you're going to need to leave, so please feel free when you need to. I see you've put your email as well. And what I was trying to do before my computer crashed was just share our feedback survey as well. So I don't know, Becky, if you're still on the line, if you could post that link in the chat, or Eileen, that would be much appreciated, just so that those who may have to leave can take a moment, because we always love to get feedback on our session and provide it to our speakers too. But yeah, did anyone else have any other thoughts around those great discussion questions or things they want to share? I think Meichi's got her hand up. Meichi, go ahead.
Hi, I have sort of a success story to share, just because I was like, maybe we should talk about some success stories. And I'd love actually to hear some success stories from people who have been in this game longer. Like, for example, up north, they have 30 years of experience. So, but one success story that I have to share, and Angie, I think you were involved in this patient's care, was, during the pandemic, there was actually like no other alternative for a while, and people had to do tele-rehab as their only available outpatient rehab. And we had somebody who distrusted technology, who, never didn't even have an email, but we knew that like for him to continue on after he goes home, to continue, and he also lived in far away from a major urban center, that his only option was tele-rehab. So I remember that we actually made him an email address, and then we taught him how to used the email. He discovered emojis for the first time and found that that it was very amusing. And he then actually did go on to do telerehab after he leave, and was brought into the 21st century as well.
Thank you. Thank you for that. And you're right. We tend to talk about the barriers and facilitators, and what comes up more in the literature often tends to be some of the ethical concerns and some of the barriers. But there are absolutely success stories, and that's what we also want to pick up on, is which groups that you might think are not people you would typically think would want or be able to use telerehabilitation, but may be able to, sometimes with additional support or like things that you mentioned. And nowadays, where there's not that obligation, that distancing obligation, it tends to be pushed aside. It's not considered as an option with people who, for example, don't have facility with technology. So thank you. Thank you for sharing that. I see a few hands. Go ahead. I don't see the names. I'm having trouble with the names. Kaylee Brown?
Yeah. So I work with Linda in the Northwest Territories, mostly in the public system. I also work privately as a pelvic health physio too, and we don't have any public options for pelvic health physio. So things like medical travel don't cover the cost for people to come to Yellowknife for private treatment. So up until the pandemic, the only way people from the communities outside of Yellowknife, for them to be able to access private services, was to pair it with like work trips or other medical travel appointments. Then with the switch to better tele-rehab options in the private sector, because in our public sector, we have pretty good technology right now. So with more tele-rehab options, that way, people in the communities that aren't able to travel now have some, although like not as like thorough access to pelvic floor rehab. So now I can do like virtual appointments with people and try and like troubleshoot virtually without having to pay like $2,000 for a flight to Yellowknife plus hotels and everything on top of the cost of the private appointment. So that's like a nice success story. And normally for pelvic floor physio, we like to see people in person for that like internal exam piece, but doing it virtually has worked pretty good. Yeah.
Perfect. Thank you. Thank you for sharing that. And I think it just highlights some of our future steps that we want to do, is try to put in place projects, teams that will kind of more influence the system, so that it doesn't have to be individuals or individual therapists who figure out how to make it work for groups that they identify as that could benefit from telerehab. So try to have some policies, some resources, some laws in place so that it is easy to use with the patients that could benefit from it. But that's not for a while. I see Rebecca.
Yeah.
Hi there.
Yes.
Hi.
Hi.
Thanks for a really interesting presentation. I just wanted to share another sort of success story and a sort of another perspective on it. So I'm in Newfoundland and I was working at the Rehabilitation Center, which is in St. John's, which is the capital, and it's quite far away from a lot of the rest of the province, but it is the main rehabilitation center for the whole province. So we often have people who come in and they will spend some time with us in person, but then are really keen to get home. They might have been in hospital for lots of months and just they need to get back home. And so I was working with a client. We were doing cognitive rehabilitation, and it's something that can be a little bit challenging to work on when we're in the rehab setting in person because we're so removed from their home setting. So this was somebody who did end up getting sort of discharged, and they went home. We were able to manage to set up. They had a partner who was very supportive. We were able to work with them to have the technology, And it meant that we were able to do all kinds of things to set up their home from that distance, because now they're there and we can sort of brainstorm, okay, what are the challenges that you're having now that you're home, and what are some of the things that we can work on now that you're there. So it was really helpful for us in terms of actually figuring out what was going to be the most help for this person, that they were actually able to be home, even though home was, 6-hour drive away from where we were in the office. But yeah, it was actually really great that we were able to do that kind of teleservice so that they could do it
so
home.
the added benefits of actually seeing the person in their home that you would not get
Exactly.
in the rehab context. Yeah, excellent.
Yeah,
Very
exactly.
interesting. Thank you. I see Sherry also with your hand. Sherry Gray.
Hi there. Thank you again for the fantastic presentation. So I am from Winnipeg, but I've been working for the last almost 3 years with physio, looking to provide service to 4 communities in rural Manitoba, including 2 First Nations communities. And we've been doing a hybrid model of care. So that's been going really, really well. I just wanted to share that as a success story. So in the year that started, I think May 1st, 2024 to May 30th, 2025, we had 611 appointments and about half of them were virtual. We did pair that physiotherapist with a rehab assistant in community. And from a facilitation perspective, that was a really, really important piece of the program. That client still had someone, if the tech wasn't working, if there was an issue or they needed a little bit of physical assistance with an exercise or something like that, that they had someone there in person. So I do think, like, whether that's someone you're training from a community, if it's a rural community, that piece has been really important for the program that we've been operating.
Very interesting. And the hybrid model seems to come out a lot.
Yes.
And I think, further down the line, that's probably what we're going to see, a lot of different variations of hybrid models. First you start one way, then you switch to the other, or combining the two throughout, or different models. But definitely, I think that seems to be something. Maybe it's also speaks to the comfort level of the patients and the clinicians, that it allows to overcome some of the concerns that they have.
Yeah, we basically give people an option, right? Like, so a lot of the research that I've been looking at also suggests, like, people should have a say in what their service delivery looks like, right? And especially if you're looking to build a service with community. So people have the option. They're not forced to do telerehab if they don't want to, but they are also informed that they will have a higher frequency of service if they're willing to accept a telerehab appointment. I think the other piece that I think we didn't do necessarily well at the start of our program, but I would highly recommend it, is I think when you're going into a community, especially when it's a really small community, there needs to be some work done to educate people about telerehab and its efficacy, and like what all of the benefits are of telerehab. Like, I think that's a piece that is often missing when it comes to implementation. Like, we do education with our providers and all of those things, but we're not doing education with the community, like having some community meetings or sessions to talk about what is telerehab, why is it a good idea, how are you going to benefit from having telerehab, those kinds of things, I think, would really go a long way.
Excellent point. And I think there's that same lack of knowledge even among the clinicians.
Yeah.
It's viewed often or as if needed,
yes,
but not necessarily as effective.
Yeah, absolutely.
Yeah.
Thank you.
Well, thanks so much. I think we'll give Sherry the last word for this session. I want to say a huge thank you again to Dahlia and Jennifer for this talk, and for all of you for coming together for one of the best discussions I think we've had since we started this thing. It's just incredible to see, and the offers to connect and take the work in different really great directions as you go forward. So thank you again so much. Those of you who haven't had a chance, please fill out our survey before you go, and we'll get the results to you, Dahlia and Jennifer, as well. So thanks so much, and we'll look forward to coming. The next time we'll come together as a group will be November 21st. So make sure that you have those that save the date for our telerehab showcase. So wishing you all a great afternoon or morning, wherever your time zone has it for you. And thanks again.
Excellent. Thank you, everyone.
Bye, everyone.